We are live, you can.
Greetings to delegates. Hope you all are safe. I'm Anjali, delighted to welcome you all to MedInnate 2021, an international virtual healthcare conference by Squad Medicine and Research SMR. Today we have an enlightening session on forensic implications of clinical toxicology sample testing by Dr. V. Pillay. A little about our honorable speaker. Sir is the Chief of Poison Control Center and Head of Analytical Toxicology and Professor and Head of Forensic Medicine and Medical Toxicology in Amrita Institute of Medical Sciences, Cochin, Kerala. Sir has his MBBS and MD degrees from Gandhi Medical College, Hyderabad. Sir has more than 100 publications in national and international scientific journals, of which 29 are included in the PubMed. Sir has authored several books, including the first ever Indian textbook devoted to toxicology, modern medical toxicology, and an exhaustive reference book called A Comprehensive Medical Toxicology, and a textbook on forensic medicine and toxicology. Sir has been the editor of Journal of Indian Society of Toxicology during the years 2005 to 2014. Sir is the external reviewer for the new edition of Guidelines for Poison Control published by WHO 2021. Sir is a working group member of the WHO's Guidelines for Poison Control Network, Edinburgh, UK. Sir has founded the Indian Society of Toxicology in 2004, of which he was the president for 8 consecutive years. It's an honor for us to have you among us, sir. Thank you so much for sparing your valuable time here, and you can take over the platform, sir.
Okay, thank you very much, Anjali, for that introduction. Greetings to everybody from Poison Control Center at Amrita Institute of Medical Sciences in Cochin. And I wish to thank Squad Medicine and Research for inviting me to this session and to talk to you all a little bit about the forensic implications of clinical toxicology testing. Toxicology is a very important, though neglected, branch of forensic medicine in our country. And it is important that all healthcare professionals and students know a little bit about how it has evolved over a period of time and how especially toxicology testing in the clinical scenario has progressed in the last few years. Since there are some forensic implications to clinical toxicology testing also, I would like to talk about this in this session and illustrate the problems with the help of a sensational case which occurred here in Kerala and that we handled. But first of all, I would like all of you to understand that this particular session is devoted to analytical aspects only. We are not touching upon clinical toxicology per se, so don't be misled by the title. It is clinical toxicology lab testing, laboratory testing, and the forensic implications arising therefrom. So thank you all, the organizers, very much for the privilege given to me to speak in this event. And let us begin the session, since time is a little bit of a constraint. Always in every event, one cannot go on talking. So I would like to wind up in about 45 minutes to 1 hour, and let us see how things go. And at the end of the session, I hope that all of you would understand at least the basic concepts of clinical, toxicology testing in poisoned victims, and what are the precautions that one must observe when dealing with such cases. I will be sharing my screen now and starting the PowerPoint presentation. I assume that all of you can see the screen, and it is clearly outlined there what I have already said earlier, and that is, I bring greetings from Amrita Institute of Medical Sciences, Poison Control Center, which is part of a deemed to be university named Amrita Vishwa Vidyapeetham. Our Poison Control Center has been in operation for the last 18 years. We have a 24-hour poison information service and an analytical toxicology laboratory. The former is listed in the World Health Organization Directory of poison control centers, and the latter, that is the toxicology laboratory, is accredited by the National Accreditation Board for Laboratories, or NABL. So before we go on to the actual topic, by way of introduction, let me tell you as to what we do here in PCC AIMS Cochin. We deal with everything that is related to toxicology, whether it is information resource or analytical services or diagnostic or treatment services. We deal with all that. We are a full-fledged poison control center in Cochin. With regard to the information service, we have a poison information unit, which is located in the emergency medicine department in the ER, emergency room. And we provide information on all aspects of poisoning, poisons, toxins, drugs, chemicals, 24 hours a day, 7 days a week, free of cost, of course. And such information is provided not just to doctors, but also to the common man, lay public, by phone, email, fax, postal mail, personal contact, whatever mode of communication is convenient to the person who wants information. We use some of the best toxicology databases, including Poisindex from the US, Toxbase from the UK, Toxins from New Zealand, and ChemInfo from the World Health Organization. By utilizing all these together, let me assure you that we can provide information on almost any toxic agent. In fact, I would say that that extends to more than 1 million substances. We have been providing such information service ever since inception 18 years ago. Now, coming to the Poison Control Center, which has a connection with the emergency medicine department, the poison information unit itself, it is actually located, as I think mentioned, in the ER, emergency room. And it is a pretty full-fledged toxicology unit. As you can see here, we are an integrated unit, the Poison Control Center and the Emergency Medicine Department. We have a unique decontamination room for poison victims who are brought. And it is very important sometimes to decontaminate the victim, especially if spillage has occurred on the clothes or the skin. So we have facility for washing the victim. We have facility for other kinds of procedures in decontamination, including whole bowel lavage or whole bowel irrigation. And we have an antidote tray also, something like a crash cart, which is devoted to toxicology. So we are pretty well equipped. And emergency medicine department as well as forensic medicine department, which actually runs the poison control center, both are NMC or formerly MCI recognized departments with the PG facility. We have postgraduates every year, and we organize regularly seminars on toxicology for MD residents of both departments. And we also have a PhD program in clinical toxicology as far as the Poison Control Center is concerned. So as you can see, pretty full-fledged and pretty comprehensive. All right, that's by way of introduction to the clinical toxicology services of Amrita. And we come to now the forensic implications of what we do. And that is with particular reference to the clinical toxicology laboratory. So the focus of my talk will be not just, clinical toxicology testing, but what are the forensic ramifications of such testing? Because sometimes this is asked by, not just doctors, by, medical students or even the layman as to how are you managing the legal aspects of toxicology testing? Because we know most of the cases of poisoning have medico-legal or forensic overtones. One cannot escape that. Even if it is accidental poisoning, still there can be forensic, issues. And many cases of poisoning is actually deliberate, kind of ingestion or exposure that is suicidal. And some of them may actually be homicidal. That is somebody murdering somebody else with the help of a poison. So we need to understand we just can't escape forensic implications when we do toxicology, clinical toxicology testing. We can't exclude forensic aspects from a clinical toxicology laboratory. All right, let us look at our own clinical toxicology laboratory as the basis for what we will discuss with regard to forensic aspects. As I've said, It is an accredited clinical toxicology laboratory, perhaps one of the very few accredited clinical toxicology laboratories in the entire country, which is quite sad because I feel that almost every medical college in the country should have clinical toxicology laboratory, and especially one that is accredited like this. In our center, the toxicology laboratory itself is located in the medical college. There are several towers in our medical college, and this is located in the ninth floor of the medical college tower proper. And you can see the equipment and methods that we use. You may be surprised to know that many of them are basic kinds of methodology that we adopt or utilize for our services, like thin layer chromatography or color tests, spectrophotometry, or sometimes gas chromatographies or HPLC, that is high performance liquid chromatography. We really don't go for very high end kind of testing. And I'll give you the reasons for that. A clinical toxicology laboratory can function much of the time with such basic equipment and methodology alone. It is not necessary to have very high-end kind of equipment that you see in forensic toxicology laboratories, like LCMS, that is liquid chromatography attached to a mass spectrometer, or for metal testing, ICP-AES, that is inductively coupled plasma atomic emission spectroscopy. We use much of the time atomic absorption spectroscopy for heavy metal testing, and that too, we don't really have it in our own center. We have a tie-up with other labs for advanced instrumentation like this. And that makes sense, because if you have very advanced kind of instrumentation, which is not very often used, you end up losing a lot of money, and then the laboratory will become non-viable. And that is why in clinical toxicology, when much of the time a doctor only requires to know whether a particular poison is present in a patient or not necessary as to how much concentration, we require, basic facility enough for such testing. We don't require, instrumentation which will give you very, very detailed, kind of information, which may not be relevant to the clinical scenario. May be important for forensic cases, but not really for clinical cases. And since ours is a clinical toxicology laboratory, the samples that we accept are mostly body fluids from poison victims, like blood, urine, stomach contents, maybe vomiters or aspirate. And occasionally we get other kinds of samples like water for potability, that is drinkability, and food or medicinal samples for contamination or adulteration, etc. So this is virtually the scope of our work, though let me emphasize that we don't refuse forensic cases if they're important to be done. Like for instance, the police bring such a case and they say that we would like you to do the analysis because very important in the interest of justice. We will undertake, and we have done that over a period of time. We have undertaken purely forensic cases also. So don't be under the impression that our laboratory deals only with clinical toxicology. We are capable of undertaking other kinds of analysis also, including forensic toxicological analysis. But much of the time, as you all know, forensic toxicology testing is done by the forensic science laboratories in India, and every state at least has got one main laboratory and several regional laboratories in some other districts. That is true of Kerala also. We have got a very good setup of forensic science laboratories in Kerala, which undertake forensic toxicology testing. And there is a regional chemical examiners laboratory also in Ernakulam, right here where Amrita Institute of Medical Science is located. And that is capable of pretty good toxicology testing, even though in the case that I'll be discussing later, will show you that there was some controversy between what happened by way of analysis there and by what we did over here in our laboratory in the form of analysis. But that is for later. And this slide will show you some of the important information connected with our clinical toxicology laboratory. We make sure that the results of analysis are available to the clinician as fast as possible, usually within a few minutes, maximum few hours. A few, of course, kinds of analysis may take several days, sometimes even weeks. For instance, heavy metal analysis, because that is the kind of procedure that is involved. But otherwise, it's usually within a few minutes to a few hours. We ensure that our reports are accessible by computer, and you can, look at the report. It will be an unsigned copy, of course, soft copy. And later on, if you want a hard copy, that will be signed, that will be sent, to you by courier if the address is given along with the sample requisition. We will also help physicians interpret every report correctly, because sometimes there can be misinterpretation. Toxicology reporting is not like biochemistry or pathology, which is pretty straightforward. Toxicology reporting can be sometimes misconstrued, and you have to be very careful. Doctors have to be very careful as to how they interpret the result, and we are always open to clarifications. So we do this clarification over phone or even personal contact in every case wherever there is some doubt. All right. Let us look at some of the common tests that we do here in AIMS with regard to toxicology. We have what is called the tox screen, which is a kind of preliminary screening for common poisons and drugs. When nothing is known as to what kind of poison is involved, we have it in stages: tox screen stage 1, stage 2, and full, depending on how many kinds of poisons are suspected, depending on how much of money is available for testing, because tox screen full is pretty expensive. Tox screen, stage 1 and 2 are less expensive, so it's all flexible. And therefore, tox screen is meant for those cases where the doctor has no idea really as to which poison is involved, or even if he has, he is not very sure. And there are some cases where poisoning is not even suspected, but it is there in the differential diagnosis. So for all these purposes, we have this so-called tox screen panel. Then we also have a substance abuse screen, because today we know in India, drug addiction, that is what the term was used till recently, today we call it substance abuse, is a big problem in India, and it is rising in incidence. So we have a good facility for detecting the common substance abuse in the urine, especially of persons who are suspected to abuse drugs. And we are constantly adding more and more substances or drugs to this panel, which is pretty commonly utilized in cases every now and then. It's a very popular kind of panel, which is a sad reflection of the situation in India with regard to substance abuse. But then that is not the focus of the talk here. So we will move on, look at the other kinds of testing that we do. We have a number of group testing. Groups like pesticides, heavy metals, alcohols, inhalant gases or irrespirable gases, all kinds of pharmaceuticals like sedatives, narcotics, anticholinergic drugs, analgesics, antipyretics, steroids. This is just a bird's eye view. We do a lot more than this. And of course, we do individual toxin analysis also. If a doctor requires a particular kind of toxin alone to be analyzed, we can do that from groups like benzodiazepines, barbiturates, opiates, or opioids, alcohols. All heavy metals can be done individually or en masse. We can do all the other kinds of pharmaceuticals, plant poisons, and as you can see, even samples of water and medicines or food or beverages, we can test for adulterants or contaminants. So we have progressed over a period of time, 18 years, from being able to analyze only a few substances or chemicals to, I think now, maybe several hundreds or even thousands of types of toxins or chemicals. We are capable of analyzing all of them. So all this is important for me to talk about, because only if you understand the basic concept of a clinical toxicology laboratory will you understand the forensic implications. So the first question that arises is, and we are commonly asked this, you are doing so many kinds of tests, toxicology tests. So are you using a lot of sophisticated instrumentation, and how are you managing? I've already given you a glimpse of an answer, and that is, we really don't utilize much of the time sophisticated instrumentation. We rely mostly on simple tests like color tests, TLC, that is thin layer chromatography, spectrophotometry, and sometimes additional tests like kit-based assays or HPLC, that is high performance liquid chromatography. Maybe 70% of the cases, at least, we utilize only these kinds of simple methods and tests. And that is very important, because you can see the advantages of basic tests or simple tests. Number one, they're inexpensive. Please understand, in clinical toxicology, money matters. The person who's poisoned may be from a poor background, or it may be a person who is attempting suicide because of maybe financial problems. You can't really inflict too much of financial burden on the family in such cases. It's a distressing kind of situation. So expense is very important. Expense is not going to be borne by the police or the government, as in forensic cases. It is going to be borne by the relatives or the bystanders of the patient. So the simpler and more inexpensive the test, the better it is. And as you can see, many of these tests easy to perform, does not require a lot of complicated kind of maneuvering to get the result. Many of these tests are very quick and may take only a couple of hours at the most to produce results that are useful for the clinician, and no need for specialized equipment. Basic laboratory setup will do, and interpretation is quite easy. And if at all you require advanced testing, then you can decide on the basis of these inexpensive tests as to whether you should go for advanced testing and what kind of advanced testing should you be doing. A related question is this: is sophisticated chemical analysis preferable if you have the facility in clinical toxicology? The answer actually is no. In fact, much of the time it is not preferable. One should not really go for advanced or sophisticated kind of testing for all the reasons that I've already stated, because it's counterproductive. Much of the time, a doctor treating a patient only needs to know whether it's a case of poisoning, and if it is so, as to what kind of poison or chemical or drug is involved. Much of the time, he does not require to be told as to what is the concentration of that drug or chemical in his system. That's important to understand. In forensic cases, yes, because the court requires such information. So not only should you be able to find out as to what kind of poison is involved, but you may also have to give information to the court as to how much concentration of that particular poison was present in body fluids and body tissues. And that is why clinical toxicology testing is so different from forensic toxicology testing. You don't have to do quantitative analysis. Much of the time, you need to do only qualitative, and that is why sophisticated analysis is very rarely required. There are also some other important points to remember. Even if you do have access to sophisticated chemical analysis, please note that some poisons may not be detected even by the most sophisticated instrument. Do not ask me examples because these are all dangerous kinds of information. But yes, as a toxicologist, I can tell you that there are some kinds of poisons which maybe nobody can detect in the body or the body fluids or tissues. And even if you can, you cannot say for sure as to whether it's a normal constituent of the body or whether it is some sort of external chemical that was introduced into the body. So there are so many aspects. Number two, by using sophisticated chemical analysis, sometimes you may pick up traces of random toxicants, and that can lead to confusion, may not have any relevance to the case, because the instrument is so sensitive. It can pick up a lot of things, what we call white noise, which can be very confusing, can interfere with interpretation. So that is why in clinical toxicology we say that always start with basic testing that can pick up the main kinds of toxicants, and traces of toxicants which may not have a role in the case at all. You don't have to bother too much. In fact, the case that I will be discussing a little later as to how complicated it became because of all this confusion relating to forensic implications of clinical toxicology testing will show you clearly that this is how it is in real life. Clinical toxicology is much of the time basic and simple, and that is how you should be approaching every case. Now, lack of qualified, experienced staff can affect performance of analysis. So if you have a very sophisticated kind of instrumentation and nobody really there to operate it or to do it properly, then again the results can be vitiated. You may get erroneous results. You may get results which are actually not reflective of what the case is. So this is also going to lead to potential confusion and misinterpretation that can result in miscarriage of justice. Number four, yes, the most important point perhaps, if you use sophisticated, very high-end equipment and you get all kinds of confusing results, there is a very real tendency for incorrect interpretation. And the result you will be giving can lead to a lot of problems. Sometimes that can be very perplexing and difficult to solve indeed. And that, I think, is exemplified by the case that we handled some time ago, and which I told you I'll be discussing in a little bit of detail in this session, so that it'll be very clear to you as to why clinical toxicology testing must not be confused with forensic toxicology testing, and why you should be very careful of forensic aspects of every clinical toxicology case. Because if you are not careful, you can end up with a lot of confusion, lot of sensationalism, lot of public time and expenditure wastage, all kinds of issues, and finally you get nothing out of it. So this particular case that I'm going to discuss is Kalabhavan Mani case. Kalabhavan Mani was an actor in Malayalam cinema basically, but he acted in certain other languages also, mostly in the form of character, roles, not really as the so-called hero that we refer to in our films, but mostly character roles, maybe comedy roles or villain roles and things like that. He's a pretty very, good, accomplished, kind of actor, and he died, and there was a lot of sensation that was created around his death because of this kind of misinformation relating to toxicology testing. I'm able to now spell out the details of this case because it has now been solved virtually. It is not sub judice anymore. All this information that I'm discussing in the course of this lecture is out there in the public domain, so there's nothing confidential. This is a case that we were directly involved with. And while some aspects I may not, reveal the identity because of certain ethical reasons, as far as legal reasons are concerned, I told you this case is virtually solved. It is a closed case. It is not sub judice. And therefore, much of the information that I'll be giving you, which is open, is already existing in the public domain. So let us look at the case as to what exactly happened and what was the confusion all about, and why the forensic aspects of this case became such a complex, kind of thing that led to a lot of misinformation out there, lot of, conspiracy theories, people, claiming all kinds of things. You will see as to why all this happened. And unfortunately, actually, much of what happened was because of wrong kind of interpretation of the toxicology testing that was done, both clinical and subsequently after Kalabhavan Mani's death, the forensic testing. So the case began on 6 March 2016 at 9:15 a.m. To be precise. I got a call on my mobile phone. I was outside the institute. If I remember right, it was a Sunday. And I got a call from the gastromedicine department of our institute that a well-known Malayalam film actor had been admitted the previous evening for chronic ethanol-related problems, and his condition was deteriorating. And he had been actually admitted for hematemesis, vomiting of blood. Routine biochemistries revealed liver and kidney dysfunction and severe acidosis, which was a real problem because it was not responding to treatment, lactic acidosis. And that is the reason why I got a call, because the doctors wanted to know, the clinicians, as to whether they should be testing the body fluids for some toxicological causes. And I said, of course, number one, he is known for consuming alcohol chronically, so definitely one should look at the ethanol in his body fluids. And since the lactic acidosis that he was having is not responding to treatment, we should also be looking at toxic alcohols like methanol. So I suggested analyzing the body fluids for both ethanol and methanol, and as a result, we received 3 body fluid samples on 6th March, comprising gastric aspirate blood and urine, drawn at 8 p.m. on 5 March. And subsequently, we received 2 more samples later on in the evening, comprising urine and blood. We did the analysis on all this. And the first three samples tested positive for both ethanol and methanol by qualitative methods. And the next two samples revealed quantitatively ethanol in the range of 19 milligram per 100 ml in the serum and 158 milligram per 100 ml in the urine, which was a clear indication that ethanol was in the process of being excreted out of the body because the concentration in urine was more than in the blood, which indicates process of excretion. We could not quantitate methanol. Please note that the toxicological analysis was being done not really to identify the exact cause of lactic acidosis, but I mean, to identify the cause of lactic acidosis, but not really to influence treatment measures, because we all know that lactic acidosis or metabolic acidosis from any cause, the treatment is virtually the same. You use sodium bicarbonate and so on and so forth. The idea was to find out the cause. And since methanol turned positive, naturally, the cause for lactic acidosis was that. The antidote for methanol is actually fomepizole or 4-methylpyrazole, but at that time, 2016, it was not easily available. And so much of the time, we give ethanol itself as the antidote. Ethanol, competes with the same enzymes for methanol and prevents methanol from being metabolized to toxic metabolites like formaldehyde and formic acid. That's how it acts. And this person was already having ethanol in his system, so it was not considered, advisable to give some more ethanol. And the actual antidote, that is fomepizole or 4-methylpyrazole, not being available, we felt that also is not an option for his treatment. And the only option available was hemodialysis. And that was done on Kalaban money in consultation with a nephrologist. But after beginning hemodialysis, it was felt that it was going to be dangerous because there are some complications that can arise. And since this particular individual was already having underlying serious health conditions like liver cirrhosis, portal hypertension, esophageal varices, renal dysfunction, all that, dialysis was not really the ideal option. Virtually, we were left, in fact, with not many options of treating Kalaburmani because his condition was so far advanced. And though at least one round of dialysis was attempted, it was not all that beneficial. And unfortunately, Kalaburmani passed away despite all best efforts on the part of the clinical team on 6th March. And this is where actually the case should have ended because it's obvious. Kalaban Mani died because of chronic, alcoholism, and no doubt traces of methanol were detected. But we all know methanol is present in almost every alcoholic beverage in trace quantities. And in a normal individual, that can be easily metabolized and excreted. But in a person with multi-organ damage, the metabolism of methanol becomes tricky. It cannot be easily metabolized like ethanol, and it has a tendency to accumulate. And that is why it was detected actually in the body fluids and led to some extent of lactic acidosis. So, normal course actually, the case should have ended here, and the death certificate should have been so and so died of alcohol related problems. You can even specify the underlying conditions if you would like. And it should not have gone really beyond that. Unfortunately, because methanol was detected, uh, it became a medical legal case. And when it's a medical legal case and somebody dies as a result of say ethanol or methanol, autopsy has to be done, and then maybe viscera analysis may also have to be undertaken. That's what exactly happened in this case. After the death of Kalaban Mani, confusion began to happen because number one, autopsy had to be done. We have actually facility to do the autopsy in our own institute. We have the permission also to do that, but we did not want to do the autopsy because there will be a conflict of interest. After all, Mr. Mani was admitted in our hospital and he died here. So the autopsy has to be done preferably by another institute to avoid conflict of interest. And that is why it was done in a nearby government medical college, considering the sensitive nature of the case. Opinion as to the cause of death was reserved by the doctor who did the autopsy pending chemical analysis. He had preserved the viscera and body fluid through chemical analysis and submitted them to the regional chemical examiner's laboratory here in Ernakulam itself. And the report came pretty fast. On 18 March 2016, the regional chemical examiner's lab gave the report, and ethanol was detected, methanol was detected. But what surprised everybody was that chlorpyrifos was also detected in the viscera and body fluid samples, and that is something nobody expected because there was no suspicion at all of chlorpyrifos poisoning. Nobody had any inkling at all that this is related to pesticides. There was no indication that somebody, was indulging in foul play, and as a result of which, Kalaban Mani died. There was no indication at all that he was depressed, and this could be a case of suicide. It was just, a natural death. That was what everybody expected. And methanol, as I said, because it's present in trace quantities in ethanolic beverages, it was not really a matter of that much of a surprise. But chlorpyrifos, yes, big surprise. And because of this, the police had to now take it up as a case of foul play. And there began the real confusion because the police had to now look for suspects. And when you say foul play, it could be in a possible homicide. So many people who were actually former friends of this deceased actor, they were all rounded up, they were interrogated, and the family of Kalaban Mani added, to the whole situation by alleging foul play and saying that since chlorpyrifos was detected, it was indicative that actually he was killed by some of his friends who had taken loans from him and were unable to pay. So in order to avoid paying, maybe he was killed. All kinds of wild allegations started, making the rounds, making it very difficult for the police to investigate. So, because of the situation where Mr. Mani was having some problems with his family even before his death because of his alcoholism, there was a lot of animosity and resentment on the part of the family, especially towards his friends, who they felt contributed to his alcoholism. And so they started naming people also, and the police had to round them up and interrogate them, put them to a lot of, kind of difficult situation. We all know what is meant by interrogation, in police terms. So a lot of, really sad things happened. And in spite of all this, the police could make no headway. And the allegations, even though they were investigating from all angles, were still remaining just allegations, and they just could not prove anything. And when the final autopsy report came, it really, wasn't last nail on the coffin, literally, because the report stated consistent with chlorpyrifos poisoning. And that was astonishing because there was no history of chlorpyrifos intake. There were no clinical findings of chlorpyrifos poisoning. When Kalaban Mani was admitted in the hospital with hematemesis, there were no features at all. Chlorpyrifos, we all know, is a very powerful organophosphorus compound, and it has got a typical kind of presentation, especially in fatal cases. There can be a lot of, cholinergic excess and clear-cut manifestations, none of which were present. And the analysis also, body fluids and all that, while he was alive and even after he was dead, except for the RCEL report, none of that indicated chlorpyrifos. And that is why it was such a surprise that the regional laboratory came up with this chlorpyrifos poisoning, which the police just could not explain. They were completely flummoxed because, as I said, no indication of suicide, no indication of homicide. So could it be, the chlorpyrifos, could it be because of accidental or deliberate contamination of something that he was taking? Or was it a contamination of viscera and body fluids that were submitted for analysis? Could the toxicology reports be erroneous? Could the autopsy report be misleading? All kinds of questions started floating around. And the police came to us and also went to other medical and forensic experts with a lot of questions. We were also interviewed by, the police, quite, a lot of grilling we faced, and we answered all their questions to the best of our capacity. And still, there was no solution in sight. So finally, the police decided, why not go for a third, kind of test and hope to resolve it as to what it could be. They wanted, the same body fluids to be analyzed by a third laboratory, maybe a laboratory which was in the forensic sector, because this is now a totally forensic case, and one of the best forensic science laboratories in India that has got an excellent toxicology unit is the Central Forensic Science Laboratory, or CFSL, in Hyderabad. And so the body fluids were sent there for testing. And in the meanwhile, unfortunately, the situation was being aggravated by, some professionals going to TV channels or the media, giving all kinds of, opinions leading to conspiracy theories. And all this vitiated. It became, a real kind of controversial topic that was daily discussed in the newspapers, on TV channels, and all kinds of theories were also floating around. We who performed the initial toxicology analysis, we did not go to the press at all, we did not go to the media, and we just stuck to our opinion and without changing at all. That is, we were very clear there was evidence of ethanol intoxication. We were very clear that there was methanol contamination of the body fluid, but we were also clear that there was no evidence of chlorpyrifos or any other pesticide in Kalaban Mani's body tissues or body fluids. And then finally, the report from the Central Forensic Science Laboratory, Hyderabad, arrived on 29 May, and we heaved a sigh of relief because, you see, they also said only ethanol and methanol detected, chlorpyrifos not detected. They did it by very, very, sophisticated kind of instrumentation. And was this going to solve the problem? No, the police were actually more confused than ever, because now they have three reports: report from the Poison Control Center in our institute, report from the Regional Chemical Examiners Laboratory, and report from the Central Forensic Science Laboratory in Hyderabad. So they were wondering as to what is to be done now, which report. No doubt two reports were agreeing with each other, ours as well as the CFSL. And the only report that was not was RCL in Cochin. But still, they just can't close the case, saying that just because it's a majority opinion, it's going to go in that favor. So they went around again, medical and forensic people, with all kinds of questionnaires and asking, as to what could be the explanation. And finally, after much time was lost, they came to us and said, please, for God's sake, help us, give us a final opinion on this case. And we said that we have been saying all along, and that is in fact our final opinion. The final opinion is Mr. Kalaban Mani died due to long-term complications of ethanol, that is alcoholism, with acute exacerbation and aggravation by methanol. And when we were asked as to how methanol came in, we said that methanol is present in traces in most alcoholic beverages. It is always present. In some beverages is higher, in some beverages only in trace quantities. And as I said, sometimes in a person with multi-organ damage, the methanol is not metabolized effectively, can accumulate, can cause problems, and excreted slowly, it can give rise to acidosis also. That was our opinion. But the police wanted to make sure. The Kerala police is pretty good, whether you believe it or not. They go to any extent to resolve a problem. So the police now wanted to find out whether traces of methanol can really be present in the body fluids of other chronic alcoholics also, and as well as pesticide traces, like in the case of Kalaban Mani. So what they did is they went around randomly choosing alcoholics in the same area where Kalaban Mani, had resided, collected blood and urine samples, and submitted for testing for methanol and chlorpyrifos in addition to ethanol. And we did the sample analysis, and we got ethanol as positive in almost all the samples. Methanol we could not detect, but of course we could not rule out trace quantities because we don't have that kind of instrumentation. And we were very clear, chlorpyrifos not detected even in traces. Now the police went one step ahead. They went to Chemical Examiners Laboratory at Thiruvananthapuram, the main laboratory, and they got some liquor samples from various beverage outlets in Kerala and submitted that for analysis to find out whether there can be traces of methanol and chlorpyrifos in these beverages themselves. Look at the extent to which the police went. I mean, hats off to them. It was a very comprehensive, very, I should say, very high level kind of investigation, which we should be proud of. This is what maybe in the West they would have done. And I'm very happy that the Kerala police went to this extent to solve the problem. And when the final results came from the laboratory in Trivandrum, many people were shocked that some of the samples actually methanol is present, even high-end liquor beverages, which we were saying all along. At the same time, they said very clearly that chlorpyrifos or other pesticides are not present. So this is where actually It should again, have ended. Even though much time was lost, it should have really ended here. But you know what happened? Even though the police filed the final report clearly stating no evidence of foul play in the death of Kalaban Mani, the family of Mr. Mani was not happy, not the media. For the media, this is, something like they can go on discussing, get, higher and higher TRPs. You know how television channels and media work. So they were not happy. They said, no, no, we don't believe this Kerala police. Let us go to CBI. And they demanded the CBI investigation. And finally, when the new chief minister came into office, he had to relent because there was so much of pressure. And he said, let us hand the case over to the CBI. So another round of, investigation began. Look at how much of time was wasted. Look at how much of expenditure went into this case. And what happened finally? CBI investigated for more than 3 years. Nothing new was revealed. And finally, they filed a closure report. It was not just a final report. They said, please close this case. 30 December 2019, the case was officially closed and featured in all the major newspapers of the country. This is from the Hindu. And it says very clearly, Kalaban Mani died of liver ailment. I mean, what did we achieve by all these, kinds of discussions and complications? And who was responsible? What really went wrong? What went wrong was this: the forensic aspects of the case. Number one, the chemical analysis report. Why did they go for a very sophisticated kind of, testing? They should have done a basic kind of testing. That was all that was required. When they did their sophisticated testing, they picked up chlorpyrifos. Believe me, in our bloodstream, all of us in India, if you look at pesticides, we will, have traces of a variety of pesticides in our systems. Almost nobody is free of pesticides. That's the situation because pesticides are used so extensively on our crops. So to get body fluids completely free of pesticides is a pipe dream. It doesn't happen. But it's trace quantities, and that is what we should have focused. Trace quantities do not mean that you should write an autopsy report, final report, consistent with chlorpyrifos poisoning. I mean, what do they mean? There was nothing on the body, no evidence at all of organophosphorus compound poisoning. There was nothing in the clinical, examination or the diagnosis, investigations, history, nothing. How can you write a report saying consistent with chlorpyrifos poisoning? These are the things that actually went wrong. I'm very sorry to say. And that is because of, I think, neglect of toxicology in our medical curriculum, that sometimes doctors don't understand how to interpret toxicology reports. And how, it's important to look at the holistic picture, not just the toxicology report, but you should be looking at the history, the clinical picture, the investigations, including toxicological investigations, autopsy findings. Everything should be taken into account before you write the cause of death. And that is what actually should have been done here. And it would have, avoided a lot of wastage of time and this kind of scandalous nature of the case. So there were a lot of wild allegations because of all this. There was a media trial, all led into this, kind of a scandalous mix. And unfortunately, now finally, 3 years down the line, after poor Kalaban Mani died, he is, I think, at peace. It was nothing but a natural death. There was no foul play involved. He did not commit suicide. Nobody killed him. It was just a sad, kind of sequence of events as a result of, his organs failing one by one because of some of his habits. And Kalaban Mani, all respect to him. He was a great actor. We all miss him dearly. But I think something like this should never happen, not just to Kalaban Mani, but to any other person. This kind of wild allegations, this kind of scandalous, kinds of discussions, this should not really happen. And if it happens because of toxicology, then we should hang our head in shame. I think the reflection of, the kind of neglect of toxicology in the medical curriculum, a case like this should expose everybody to the importance of toxicology. So if anybody would like to know more about, cases like these or, kind of toxicological information from the forensic perspective, I would humbly like to suggest one of my own books, which is pretty popular among medical students. It's in the 19th edition. I also have a textbook exclusively dedicated to, doctors who are treating poisoning cases, that is modern medical toxicology. And of course, anybody wants details of poisons or poisoning, there's also a comprehensive book authored by me, in fact, titled Comprehensive Medical Toxicology. So I think I've got a book almost, directed to everybody, a level of interest in toxicology. And if at all there is somebody who does not want to read at all, at least do attend our conferences. We have a society dedicated to toxicology. And the 15th, conference is coming up sometime this year. Exact dates not finalized because of this terrible epidemic which is still going on. But we hope to have it at the end of this year. And we hope that the audience who are very patiently listening to this talk, many of them will register for the conference and get to know more about this very fascinating but misunderstood specialty of toxicology. So I would like to thank you all very much for this patient hearing. And of course, thanks to the organizers for giving me this opportunity. Thank you all.
Thank you, sir. Thank you so much. This was a really very informative session. Like with especially in the situation in our country with the increasing crime rates, and the medical system has to be very attentive. Like they have to be very careful in, especially when a cases come like this, they have to be very careful in analyzing these cases. They should make sure that no mistakes are made during diagnosing the what is the condition here. So this session really was helpful. Like even when to understand if a certain person comes with some poisoning, we should not go directly towards the sophisticated diagnostic measures. We have to do it like what are the standard measures we usually follow. So this is very informative, sir. I really hope all of our viewers really found this informative. Thank you so much, sir, for your valuable time and session.
Thank you. Thank you for the opportunity.
Like it was really great, sir. Like it was like watching a crime thriller.
Yeah.
Exactly.
I think we can make a movie on it. So, like I really expected this.
In fact, Netflix is planning a small documentary on the importance of toxicology. And I cannot reveal anything much, but there are many more interesting cases that will be discussed in that documentary when it is released, hopefully by the end of the year or maybe early next year.
That's really great, sir. It will be a platform where more people will get access to. And one more thing I want to add is I recently passed my second year, sir, just two months back. Okay. I referred your publication book, a book for undergraduates, the forensic medicine and toxicology. It really helped me to get through. It was so very interesting, sir, because sometimes studying for long times could be monotonous, but the cases you included in between, the history of the cases, the way you described all the cases are really awesome, sir. Whenever I felt monotonous or bored, I used to refer all the cases, and it helped me a lot, sir. Your book. Thank you, sir.
Actually, that book is, as you very nicely point out, quite popular, especially among students. But some of colleagues are not very happy because say that the book is written almost like a novel. It's not like a textbook. And I say, a subject should be made interesting for a student to read. That is the current approach. You look at, Western books, even books on medicine, microbiology, pharmacology, they're all completely different from what I used to read as a medical student. Everything has changed. Now, you have to grab the attention of the student. Otherwise, if it is a monotonous book, you will be forced to pick it up only at the time of exam, somehow cram some information. And that is not, how it should be. Many of the specialties are very fascinating, not just toxicology or forensic medicine, many others. If you write it well, if you teach it well, I'm telling you, you can really arouse the interest of the students. And that is our job as teachers. We should arouse your interest. And if that has been done, I'm very happy that students are expressing that kind of appreciation, but do give me your feedback also as to how to improve it further in future editions. Thank you. Thank you for your kind sentiments.
Yes, sir. I hope all delegates will enjoy this session. Please proceed for vote of thanks. Sir, and please stay for 2 more minutes so that we can have a group photo.
Sure.
So thank you all viewers for joining today's session. We all hope that you enjoyed it. So thank you and stay safe.
Thank you all. Take care. And thank you, the organizers, very much. Goodbye. Best wishes for the rest of the event.
Thank you, sir.